Jeff, it is so good to have you on here. Thank you so much for taking the time to be a part of this. I've been looking forward to this conversation. So thanks for being with us today.
Oh, you are welcome.
Jeff, I'd love for you to just start out telling us a little bit about what your work is, what you do, how you got into this work, and kind of what drives you as you do this kind of work.
Well, there's both the professional and then there's the personal. I come from a family of committed individuals with alcohol use disorders.
Mm.
And if anyone in your audience wants to laugh, they should Google Georgi vodka, and then they will understand why that is the case. It is unclear exactly what that vodka has in relationship to my family, but
Yeah.
it speaks volumes in terms of the reality that I grew up in a home where there was active alcohol abuse and truly both parents had alcohol use disorders. My dad was one of those high functioning, extremely successful individuals. And my mom struggled probably with other psychiatric illnesses, but they did the best they could, which really, I think, underlines everything I hope to say today is that I think parents do the best they can, and they're just things that trip them up along the way. So I became really interested in that whole topic. And then when I was working as a chaplain at Memorial Hospital in Chapel Hill, but it's not called that now, but back in the late 70s, everywhere I looked, I saw addiction that was not being treated, completely overlooked. Even though the clear reason behind they might come in for a horrible infection in their arm, but what caused the infection was using a dirty hypodermic needle to inject a drug, and that was never addressed. So I took those two pieces, the personal and the professional, and went back to school. Got another master's from Duke in allied health, focusing on addictive illness and what we knew at the time, and then just got lucky. And what I mean by that is I've had the privilege of working with some of the real pioneers in that field, in the field of addiction, and I've been doing it a long time. And but the foundation that was laid was, in a lot of ways, luck on my part. I was in the right place at the right time. I had supervisors who really wanted to give me the time to read and to expand, and so that's how I got started, and it's been wonderful ever since.
Yeah, that's so great. And it's so helpful to hear kind of your own personal heart in this work and just kind of that part of it. One of the areas of your focus for more than 30 years now, I guess, has been the impact of alcoholic family systems on the children who grew up in those contexts. And there's some terminology that might be helpful for our people to understand first. And that's a big part of doing this podcast, is to introduce people to these conversations and to some of the terminology. And so can you tell us what it means or what we mean by adult children of alcoholics or adult children of dysfunctional families? And then are there other terms that might be helpful for people to know?
Absolutely. I first want to start out by saying all of the terms we're going to use are descriptors, but not diagnostic categories. So when we talk about adult children of addiction or adult children of alcoholics or adult children of alcohol, ACAs, there are all sorts of acronyms that people use, but none of those are meant to be diagnostic. They're more descriptive. And in my opinion, and you've already said it, but it really boils down to the reality that all of people in the categories we'll be discussing come from family systems that were dysfunctional, and almost all of them were dysfunctional to the point where there was a level of trauma that impacts the kids that come out of that system. So it's it's almost, although this is not a popular title in terms of that sense, but we're really talking about children of dysfunctional trauma, children of dysfunctional families with a history of trauma.
Mhm.
That's the broad descriptor, but there are all sorts of other acronyms from for your audience. It's important for them to know that there are some self-help groups that reference ACA. And if they see that, that's just a shortened version of adult children of alcoholics.
Mhm. Yeah, absolutely. And I've seen, as I've done some of this work, the ways that even what began as adult children of alcoholics, this acronym has expanded to include children of adversity of different sorts,
Right.
that are coming in and sharing those experiences. Tell me a little bit, just briefly, just for the sake of kind of clarity here. My understanding is, the term alcoholic is not one that we're using, or that's not used as frequently. Can you say a little bit about that and why that is?
Yeah. I don't use it. I certainly don't use it professionally. The diagnostic statistical manual on mental health is in a sense kind of the Bible for mental health practitioners, and it's moved away from some of the older titles. It doesn't even use addiction, although it doesn't say that that's a taboo word. But what it has put in place is substance use disorders.
Right.
And of interest, I think at some level it's got a real sensitivity because there's a gradation. You can have a mild, moderate, or severe substance use disorder, and then you plop the drug of addiction in there, and so it would be severe opioid use disorder, severe
Mhm.
alcohol use disorder. Um, so it's a little bit more, in my opinion, both clinically accurate and descriptive.
Yeah, and my understanding, kind of the terminology of people first language, moving away from this term defines all of a person
Right.
versus a person who is dealing with alcoholism. It's one aspect of who they are as a person, but it doesn't define them entirely. Is a bit of it, similar things with disability. A person with a disability versus a disabled person. Some of those kinds of things is my understanding of a little bit of that too. Well, for myself, as someone who grew up in a alcoholic family system, one of the findings that has been most helpful for me is understanding that many of us who grew up in such context share some unique traits in common. And just to share a little bit, it was when I first began to discover that there were some similar traits. I remember reading Janet Wartit's book on adult children of alcoholics and reading kind of her 12 characteristics. And as I'm reading this, I'm thinking, no, not everybody's this way. Like this is me to a T, but I didn't realize like there were some unique things. And so I know you've done research on this. Could you share how you came to these findings and share what some of them are?
Sure. I think certainly Janet Wildis was a pioneer in this field. And over the years, some of the things that she said obviously have been eroded by more up to date research. But I think the global sense that is really important, that's embedded in her work, is that kids who grow up out of an addicted family or addicted system really don't know what normal is. But that's not any different than any other kid. In other words, our family is the way we think all families are
Yeah.
until we get old enough to we start socializing, get in school, start spending time in other people's homes, and we go, oh, they actually sit down at a reasonable time and have dinner rather than
Yeah.
this chaos that I live in. So, so what she talked about was this difficulty with being knowing what normal is, a real sense often of feeling empty and not quite knowing what you're missing. Um, I think the interesting piece to this population is that they tend to be grow up to be kids or adolescents and then adults of extremes, like they're either very, very responsible or they tend to be irresponsible. They tend to swing between the two polarities. Um, they they often have control issues. And so because they grew up in a household that's chaotic, so they're going to want to try and control what they can control. And sometimes they place way too much energy in controlling things they can't truly control. Um, I think there are relational issues, and the reason for that is that they didn't have a good, clear template for what a normal, healthy relationship looks like.
Yeah.
So when they start experimenting relationally and trying to figure it out, they don't really know, and that's a problem.
Mhm.
Um, Also, the people pleasing piece is important. I do think we overuse that a bit, but it's that sense that I somehow need to earn a person's trust in me. So I'm gonna work really hard to get that done. Underlying all of these, and Janet certainly had more than, I mean, she talked about all sorts of things, the exaggerated sense of loyalty and the the incredible sensitivity to embarrassment, and all of those, I think, are manifestations of the internalization of shame.
Mhm.
And shame is that sense that we're just not good enough, that we're not worthy. And if you can, because of the family you grew up in and because of the
Yeah.
family I grew up in, um, I certainly felt that my parents loved me, but it it wasn't consistent.
Yeah.
And so there, you grow up as a kid wondering where is my value, and one way of finding worth, if it's not automatically internalized, is to work hard and do good.
Mm.
And so if you don't feel like you're good enough, you do good and you do lots of it and you keep
Yeah.
doing good.
Yeah.
And so it's one of those weird things where a negative in the eyes of our culture often turns into a positive, because this group of people will work really, really hard to meet the expectations of others. And if those others happen to be teachers or professors or whatever,
Yeah.
you're going to find people who have good outcomes.
Yeah.
So it's a weird kind of double-edged sword. But underlying all of these characteristics, and I could list off a bunch more. I think it's that sense of just not being worthy,
Yeah.
that I don't quite measure up, and that's the voice of shame.
Yeah, I think that's such a crucial point. Can you say a little more about how that shame arises out of that particular context of an alcoholic family system or some kind of dysfunctional family system?
Sure. Uh, in a weird sort of way, COVID gave all of us a experience
Mm.
that was sort of like growing up in an addicted world, because you and I talking to each other through the medium of Zoom is a good thing, and it's neat, and it allows for a level of communication that is more than just talking on the phone.
Mm.
However, there's an internal part of the brain, the central core of the brain, called the limbic system. Is the part of the brain that is the originator of emotion, and the part of the brain that empathetically connects with other people.
Mm.
And the problem with, in a sense, using a virtual world as your default for communication, which most of us did during COVID,
Yeah.
you don't pick up on those limbic systems, those
Mhm.
limbic feelings. And we all have, for example, a feeling about family.
Hmm.
When we close our eyes and think of family, we can start naming people and all that, but we can feel family in our bodies, and um, that's the limbic system, and that was denied us in terms of interacting with other people in COVID, but that's also what gets messed up in families where there's addictive illness. You've got a parent saying one thing, and if they're altered, the kid is picking up on that limbic shift, and so the mother is saying one thing, but the kid is picking up a very different message that's not being articulated. So it's confusing,
Yeah.
and they even when they're praised, or even when they get what they might see as positive affirmation, if that person is altered even slightly, it's going to come across at a limbic non-spoken level as a garbled message.
Wow.
So it's that level of confusion that leads the kid to wonder, why am I not good enough for mom and dad to be 100% present with me?
Yeah. Yeah.
And that's where I think the real impact occurs.
Well, and when it's nonverbal, but you're still picking up on something, there's this sense of this doesn't feel right, but is that because something's wrong with me?
Exactly. And of
Mm,
course, that's our default.
yeah.
When we're little people, when we're kids, we can't blame mom and dad because we're dependent on them.
Yeah. Yeah.
So therefore, if things aren't going right in the family, it's got to be our fault because
Yeah.
it's literally too scary for us to think that mom and dad may not have it all together.
Yeah. Well, and I also heard somebody say recently that as children, because we don't understand the dynamics, we're not self-aware enough to understand that these are individual humans apart from us. We essentially see ourselves as omnipotent, that everything happens as a direct reaction to our action. And so if a parent is angry with us or responds in a way that's overly harsh or critical, our thought is, I must have caused this. This is
Exactly.
my responsibility. I did this and they responded, and so it's my fault. And that just made so much sense of, why we read things off of those experiences in ways that we do. But you know what, you said one thing a little bit ago, and I want to drill down on this a little bit. Talking about how for children who grew up in these contexts will swing to one pole or the other, to be super responsible or super irresponsible. And I think, when we first hear that, we think, well, how could it be both? Or how could it be either one? Can you say a little bit about why someone might end up being super responsible, whereas another child, maybe even in the same household, ends up being super irresponsible?
Sure. A lot of that has to do with birth order.
Mm,
And if you're the firstborn child, and you've got a, a family challenged by active addiction of some variety or any other major dysfunction, um, you may see the need for things to get done, and they may literally turn to you, and it's not, again, it's not parents intentionally messing their kids up.
mm,
But if they're having a hard time cooking a meal or organizing the house, uh, by default, that will often fall to the oldest child. And so they grow up with this sense of exaggerated responsibility and at times exaggerated expectation that they're supposed to be able to do all these things, kind of like you were saying before. So then the second kid comes along and he looks at what the first kid is doing, and he concludes, or she concludes, I can't compete with that. So their swing might be to, if I can't compete, I ain't going there.
yeah.
I'm going in the opposite direction. Um, and And so a lot of it has to do with birth order and the level of dysfunction. Um, in it's really rather dramatic how many very, very successful, I mean, big time successful
Mm.
people come from dysfunctional systems and actual families where there was active substance use disorders. And I used to know the actual statistic. A lot of presidents of the United States came
Mm,
from those kinds of families,
yeah.
and a lot of some of the super successful businessmen and women come from that kind of family. So it's an interesting it's an interesting dynamic because of those extremes.
Mm,
Um, they're they're just, again, they don't know what normal is, so they're gonna try to find their place in this chaotic world and make sense of it however they possibly can.
yeah.
And if one slot has been filled in the family hierarchy of children, they're going to choose another slot.
Yeah.
Not
Yeah.
intellectually, they're going to sit down and go, okay,
Right.
but that's the slot they're going to slip into.
Yeah. Yeah. Well, so as a therapist who's worked with people struggling with addiction as a psychotherapist, how have you seen these common characteristics uh, impact their relationships as adults? Are there some common ways that these impact relationships? How does that tend to play out?
Well, I think that's where the biggest issue is. Um, they uh, when we talk about uh, how kids understand what relationships are, um, the place they're going to look, obviously, is their parents,
Yeah.
and so they grow up in a sense with a altered or an abnormal relational template, um, and there are a bunch of fancy psychodynamic words for that, but the important piece is they don't have a sense of what a healthy relationship looks like, so they kind of have to make it up as they go along.
Mm.
And that's where some of the people pleasing can get in the way. I mean, a healthy relationship is a give and take, and sometimes you go along with your partner and sometimes they go along with you, and you know how to navigate that and all of that. In an addicted system, however, it doesn't go that way. I
Yeah.
mean, usually if and this is just being archetypal, it's
Sure.
not making this an example, but if dad's got a severe alcohol use disorder and he comes home, all of a sudden the whole house focuses on him because he demands that, and his energy demands that. Um, so kids grow up with this altered template, and then when they start forming adult relationships, what we tend to do, as upsetting as this is we tend to connect with what we know.
Yeah. Yeah.
And so if you came out of and you see it clinically so often, you'll see a really bright, just wonderful human being having these consistent relationships with individuals struggling with a major substance use disorder.
Mm, yeah.
And there's a natural part of some people wondering, why do they keep doing this?
Yeah.
Why can't they learn?
Yeah.
Well, they don't, because that's the relationship they know.
Yeah.
And so they may get out of a relationship where the spouse was struggling with alcohol use disorders, and then they get into another relationship where the person has a cocaine use disorder.
Yeah.
And it's not like they can't learn, that's what they know.
Yeah. Yeah.
And we tend to do what we know.
Yeah, you mentioned earlier kind of the limbic system, and one of the most fascinating things I've read, it was in A General Theory of Love that you had recommended, and he talks about in there how uh, we develop this comfort with what's familiar
Right.
in terms of our emotional state and our relationships. And we look at someone like you said who finds themselves in similar relationships over and over again and think like, how many times do they have to be in a relationship like this before they learn don't go in that kind of relationship? But the reality is, because that limbic system works on such a non-verbal level, a subconscious level, uh, we gravitate towards what we're comfortable with. What we're comfortable with is what we're familiar with. And so even though it is dysfunctional, we're comfortable in that space. And man, that was just so helpful for me in understanding these dynamics.
Well, and that also helps people understand why people stay in abusive
Mm,
relationships.
mm,
And it is so easy for those of us on the outside to judge, and again, I'm speaking stereotypically here, but
sure.
to judge that woman who doesn't leave a domestically abusive household. Well, if she came out of a family where there was a physical abuse and that's what she
Mhm,
saw, she's got this heightened sense of loyalty that we've always kind of talked about, but that's what she knows.
mm,
And this is a bit of a leap on my part, but I also believe that that's where shame comes in.
mm,
At a nonverbal level, that's what she believes she deserves. She doesn't recognize that she truly does deserve that loving, nurturing,
mm.
caring individual in her life because she didn't see it. She
Wow.
didn't see it growing up. She doesn't know what it looks like.
Yeah.
And to go back what you said, you're absolutely right. Limbically, we're not reading this on a piece of paper, but it's imprinted in our brain limbically, and so we are naturally drawn to what we know.
Mm. So, a major contributor to these conversations and understanding of our childhoods has been the ACE study, Adverse Childhood Experiences Study. And this was conducted by Robert Onda and Vincent Felitti from 1995 to 1997. Can you explain what this study was about and why it was so significant?
Yeah, it was huge. Number one, and it in a lot of ways it was initiated by a collaboration with a bunch of academics, but also with an insurance company, Kaiser Permanente,
Interesting. Yeah.
and they wanted to figure out, in terms of their own liability, is there any way based on a history that we can determine who we can afford to
Of
insure
course.
and
Yes.
who we can't. Um, and it turned into one of the most powerful studies that has ever been done because it was done over a lot of years. It started all the way back in the middle to late 90s, and it went for 20 or 30 years.
Wow.
And so it followed these people, and in a very global sense, ACE stands for Adverse Childhood Experiences. And the categories they sort of fall in are physical abuse. Now, this is important. It doesn't have to be physical abuse directed toward the child.
Mm,
If they see domestic abuse between the spouses, that is still a very scary and internalized dysfunction.
yeah.
So it's physical abuse. Obviously, sexual abuse can be just devastating. Uh, Rageaholic parents, I mean, emotional abuse.
Mhm.
Um, Seeing it's a powerful thing to see either parent being treated in a degrading or shaming way. That has a profound impact. And then the global things like a substance use disorder in the household or a parent who is incarcerated. Um, we sadly in our culture have a very high divorce rate, and that impacts kids.
Yeah.
So all of these major events um, become these adverse childhood experiences, and what they were able to do was uh, they can evaluate over time. If you have one of these things, no big deal.
Mhm.
Now, obviously, if it's profound sexual abuse, that would change. But by and
Right.
large, one or two adverse childhood experiences um, are things that the child can overcome. When you get to the three, four, and five, a number of these, that's when you begin to see not only psychological problems growing up, but physical ones. Here comes the insurance, the health.
Yeah. Right.
Kaiser Permanente is the health insurance company, and what they were seeing was somebody with five ace a score of five, and those five of those things I just globally talked about, they're going to be more prone to heart disease. They're going to be more prone to vascular disease, more prone to cancer. Now, again, I want to be very clear to your audience that this is not destiny.
Right.
These are statistical conclusions, because what we've in the last 20 years, there's been the pendulum has swung, and maybe we'll have a time to talk about the pendulum has swung to resiliency,
Mm.
because everybody, and I'm sure that you have seen in what you do in the ministry, you've seen these folks that come out of families that just are really challenged by a whole bunch of these.
Yeah.
And so naturally, that kid grew up with an A score of a 6,
Hmm.
and yet they're loving, they're nurturing, they're responsible to their children, and you kind of look at this and say, well, how is that possible?
Mm.
What we've learned, and that's why I want to emphasize that the ACEs are just a statistical correlation,
Yeah.
but we've also learned that even in the face of all of those, if there are certain resiliency factors that are also part of that child's experience, they can, in a sense, undo
Mm.
the energy of the adverse childhood experience.
Yeah, that's so helpful. So tell us, what have been some of those resiliency factors? What has led to some of that?
Well, um, they're a bunch, and I mean globally, the Harvard Center for Childhood Resiliency is one of the leaders in this field, and um, what they looked at, again, exactly at the kind of kids we're talking about, kids coming out of systems that were dysfunctional, where there was a lot of abuse or trauma, and they began asking the question, okay, what else was going on, particularly in the face of this child who's doing well,
Yeah.
and in a global sense, and I may even go over a few of them individually, but in a global sense, um, as long as a child has one adult in their life that they know loves them, and if the family or the child is able to get support and acknowledgement from outside the family, even if the family is struggling, um, then you're going to begin to wipe away uh, some of the power associated with those aces. So the
Mm.
categories, and I'm not going to really, unlike the ace, which is a yes or no.
Uh-huh.
Yeah, either you had a family that was incarcerated, or you didn't. A
Yeah.
yes
Yeah.
or no. So it's binary. The Harvard scale is a Likert scale, meaning that there's this all sorts of little categories, from
Mm.
definitely true to probably true to not so sure to probably not true to definitely not true. So
Okay.
there's a and but just for your audience, I'm going to go through them briefly, but
Yeah.
and I think this will make sense. So these are the positives. If you answer these questions, definitely true, you're going to literally be able to rebound from the power of those adverse childhood experiences. And they are, I believe that my mother loved me when I was little. I believed that my dad loved me when I was little. When I was little, other people helped my mother and father take care of me, and they seemed to love me. So again, if you got a definitely true to either of those three, that's
Mhm,
all of it positive.
mhm,
Um, I've heard that when I was an infant, someone in the family enjoyed playing with me.
mm.
When I was a child, there were relatives in the family that made me feel better when I was sad or worried.
Wow.
So connection to a larger family network. Um, when I was a child, neighbors, and this is going now outside the family, neighbors or friends of my parents seemed to like me.
Mm,
This speaks directly to you. When I was a child, teachers, coaches, youth ministers, or ministers were there to help me.
mm,
Um, someone in my family cared about how I was doing in school. And then here's some more internal dynamics. We had rules in the house, and we're expected to follow them. Imagine a kid coming from a home where there's active addictive use. That's chaotic. If
yeah.
there are rules, then a kid feels safe. Rules
Mm,
are good things for kids if they're not overdone.
yeah.
Um, when I felt really bad, there was someone that I trusted that could talk with me.
Mm,
Um, and so there are a whole series of these. There are just a couple more I want to reference.
yeah.
One is I was brought up to believe that life was what I made of it.
Interesting.
And this sense of I have in my own hands a sense of agency. I can get through difficult times. Um, and then the last one is that as a youth, as a child, I I I could get things done.
Mm,
So it's really important, again, for your audience to realize that the ACE study is important and real,
yeah.
and they should pay attention to it.
Mhm,
But at the same time, they should also look into this notion of
yeah.
how how did you within the family survive some of the challenges that you faced, but also were there these outside um, supports available to the child that gave them a sense that they were valuable.
That is really, really helpful. I think even just reading those questions on the Harvard resiliency list of questions there, I think it can be so easy to look at, there's 10 questions on the adverse childhood experiences evaluation, and it's easy to look at those and kind of be overwhelmed or
Mhm. Yeah.
really just discouraged by, your number, 4, 5, 6, on up. But to hear these questions and think, actually, that was true. There was somebody that I could think of that enjoyed playing with me as a child. There was some, I knew that my mother loved me. Those kinds of things, that is refreshing. It's a reminder of expanding our imagination of what our childhood was like for some of us. I mean, obviously some of us, we had so much tragedy happen, but to be reminded of those other elements is really helpful. How do you use these in your practice? How do you utilize these tools?
Um, when uh, I have a rather unusual way of an assessment. I don't sit down and have this endless list of questions that I ask people. Um, Number one, I think that can be kind of scary,
Yeah.
and can kind of push people away as if I'm only interested in the content of their life, which is sure important, but I want to get a sense of what's important to them.
Yeah.
Um, how I use these is I know them well enough. They're sort of in the back of my head, and when I hear them talk about their childhood and talk about and I hear this often, a kid will say, I yeah, my dad punished me, and I think actually, he used a belt when he punished me, but I always did something wrong and deserved it.
Mm,
So there's a bell going off in my head. Ding, 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 ding. The kid, literally, the guy who's telling me this, doesn't see that as abuse,
Right.
but it is.
Yeah.
And I'm not going to jump in on there and say, "Wow, that's a really no." That would be unthinkable. But what I allow people over time, and I have the luxury because I'm in private practice now, of allowing a person when they're comfortable to fill in some of the pieces. And so I do pay attention to the
Mhm.
ACEs uh, when I hear them talk about one of those resiliency pieces. I will often call attention to that. So let's say they had a teacher that they mentioned, and I might say, "Wow, that really sounds important. Can you tell me more about your relationship with him or her?" Um, uh, if they talk about a pastor who really paid attention and took him to play and took him out to a park and whatever it was that they saw as important, I want them to talk about the positive, not ignoring the negative, but
Sure.
that begins to for them to paint this picture um, of what I think is probably the most positive attribute of children who come out of addicted systems or dysfunctional families, and that is they're survivors.
Mm.
They have learned how to navigate a really challenging world, and most of the time they've had somebody, teacher, pastor, friend, social worker, somebody
Yeah.
in their life who's cared enough about them to help them walk through the minefield of the dysfunction in their family. And I think that's a real attribute.
Yeah. Absolutely. So good. So along those lines, the focus of this podcast is looking at the ways that our difficult or dysfunctional childhoods have formed us in ways that may have actually helped us have healthy relationships now. The key thing there is understanding that it's not automatic. That there are things that we have to overcome, but in overcoming those, there's also parts of that can actually prepare us for healthy relationships and give us some tools that we might not have had otherwise. And so I'm wondering if there's certain aspects, being someone that's been in this work for a long time, certain aspects of adult children that you tend to admire in clients or ways that you see them overcoming obstacles that help their relationships thrive.
Um, Globally, I think the development of healthy relationships for people who come out of profoundly dysfunctional families is the most challenging.
Yeah.
Um, because they've got that template that we talked about earlier. They don't really know what is healthy. They don't know what is normal. They don't know um, that they deserve respect and nurturance and mutuality. So I think the relational piece is the toughest for this patient population. Um, Again, not diagnostic, but problematic. What is impressive is their tenacity,
Mm,
their ability not to give up, um, their ability. One of the neat things about this population is they are really good in a crisis
yeah.
because they've lived in one, so
Yeah.
they know how to navigate that. And
Wow.
so if suddenly they're in a relationship and that identified partner falls ill or gets cancer, they click into crisis mode and they get things done.
Mm,
So there's a lot of skills learned in adversity that can be applied to the natural challenges that life just throws at us because that's life.
absolutely.
And and from that perspective, I think there are some positives. But I do think that if I were again to make a global statement, um, this group of people struggle the most in relationships and find that if they choose to get some kind of support themselves as they grow up and become adults, that's going to be the area that they're going to see the most change in.
Yeah. 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 One of the things that I've leaned into just for myself is, looking at my own parents' relationship and thinking through their kind of dynamics. There were so many times that I remember thinking, man, if they would just do this, or if they'd just be
Mhm.
willing to do this, whether it was to get help with alcohol use or whatever it may be. But it always seemed like there was something more important, or a higher priority, whether that was pride, or the unwilling to acknowledge that need for assistance and help, or the desire to have the healthy relationship above kind of a coping mechanism, whatever it may be. um, and so I think one of the things that I realized in myself was seeing where it goes, where the relationship goes when we choose not to take those steps, had created this desire in me to see my own relationships be healthy at whatever cost. So for myself, at times struggling with mental health, it's something I've shared about. um yeah, I could say, you know what, I'm going to resist getting help for that because I don't to acknowledge that I need that help. But I know the flip side of that is that's going to hurt my relationships. It's going to hurt my relationship with my wife, with my kids. And so weighing that out and thinking, you know what, my desire to see this relationship go differently than, say, my parents' relationship drives me to get that help, regardless of kind of the humility it takes to acknowledge that.
Right, right.
And so finding for myself this intense drive for healthy relationships, even if that means I've got to do a lot of work to learn what that means, what
Mhm.
that looks like. Well, if someone is just starting out on this journey to understand the impact of their childhoods and their difficult childhoods on their relationships now, what would be some first steps that you would encourage people to take?
Well, you sort of just a li- uh, you just listed a couple. I think I think it's important for all of us to 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 start with the recognition that our parents did the best they could.
Mm,
That didn't mean that they were perfect parents, but that they did the best. I have been doing this work for over gracious 45 years
yeah.
plus, actually longer than that. That's a little scary. But the I have never met, well, that's not true. I was about to say I've never met um, any parents who had children in order to abuse them.
Mm,
I've actually met two. I didn't meet the families, but I worked with two kids
mm,
who came out of a system that was true for, and they happened to have been kids born into relationships that were satanic,
wow.
literally worshiped Satan, and they had kids in order to make them sacrifices.
Oh my goodness.
And some of the, but as horrible and almost unspeakably horrible as some of the things these kids lived through, they lived through them,
Yeah. Yeah.
and they found their way to a helping professional that that over it took a long time, but for
Wow.
both of them they weren't related in any way. They just I don't, but those are the only two I've ever worked with. But
Yeah.
the, one really was able to claim a level of health that I would consider healthy normal.
Yeah.
The other continued to struggle, but they were aware of their struggle, and they worked really hard not to take that into their relationships and their own parenting.
Yeah.
So back to the more normal, um, I really believe that parents are doing so. It's important, really. This is a big thing for me. I think parents do the best they can. I did the best I could as a parent.
Yeah.
Was I perfect? No, I was not. But I did what I did because I thought at the time it was the right thing. Um, so that's the baseline.
Yeah. Hmm.
Then I think it's important for people to realize if they can look at that ACE study, which is easy to Google, not getting overwhelmed by their ACE score because it's balanced by the resiliency score. Um, to start asking, am I at a place in my life where I can get some kind of support for this? And the first line would be non-professional support, and there are lots of those. There's obviously Alcoholics Anonymous. There's Al-Anon for the families of people who have that disease. But there's also an ACA group, and that literally is a group of people who grew up in this kind of system and get together on a regular basis. They even have a book. It's called the Big Red Book,
Yeah,
and it's wonderful.
it's
And if
amazing.
when you start reading it, you go, "Oh, I'm not crazy. There's other people like me." You know.
It's amazing.
So this that first step into encountering and being able to really begin to connect with other people like you, because part of we didn't talk that much about it, but part of the the struggle that these kids have as they grow up is broken relationships, and that leads to loneliness.
Yeah.
A bit off of our topic,
No,
it's so
go for it.
important. I want to is a wonderful book by our current Surgeon General Vivek Murthy called Loneliness. The healing power. No, it's called Together. It's called Together. The healing power of connection in a sometimes lonely world.
Mm.
And it is just wonderful. And he talks about connection, alone time or loneliness, and then he talks about solitude. Loneliness is a bad thing.
Yeah.
Loneliness is probably because we are driven as human beings to connect.
Yeah.
That I mean that's of the many attributes God gave us, that's a big one.
Yeah.
And we need, and he would say that word need, other people in our life. Um, but he also talks about the importance of solitude.
Mm.
And based on your genetic makeup and your life experiences, you may need more solitude, alone time, to think, to meditate, to read, while and that might be, you might be more introverted, while an extrovert's going to be, they're going to, if they're not doing something with other people, they're kind of unhappy. And
Yeah.
so although they still need some alone time, they 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 don't need anywhere near as much solitude as that introvert. So the point in terms of ACA is to try to figure out, where am I on that spectrum?
Mm.
Am I hiding from other healthy relationships? And if I am, it's going to be hard for me to go to one of those meetings.
Mm.
So maybe I can talk to my pastor.
Mm.
Maybe I can find a friend who has a kind of a similar history to me,
Mhm.
realizing that trusting others is going to be hard for this population.
Yeah.
Um, and I believe eventually, if possible, professional help works. I mean,
Absolutely.
I for years ran a program at Duke specifically for this population, and we used a individual, but more emphasis was put on a group experience, where they would get together with a professional, and they would talk about what their lives were and how they experienced each other in the circle, and often how they would recognize that they were feeling judged by somebody who was really trying to tell them that they cared about them.
Hmm.
And
Hmm.
how they and what they learned was how their internal coder is set kind of backwards sometimes. So I really think that for so many of the patients I've been privileged to work with, um, finding that, and going back to the Harvard study, finding that willingness to get outside of your own family, outside, for that matter, even of your own history, and to begin to look at it um, with a nurturing, caring other, is tremendously healing. And so I think there really are avenues for this patient population to get the kind of help that leads to really good outcomes.
Mm, yeah, that is so good. There's one more thing that I wanted to ask you about, just kind of going back a little bit. This is going back to an early part of the conversation, but I think this is so important. Knowing that you've done a lot of work on shame and the role of shame in addiction, uh, and knowing statistically how many of those of us who come out of these alcoholic family systems end up in some sort of addiction ourselves. Can you share a little bit of what you've learned or what you've developed in terms of that connection between shame and substance use disorders?
Um, sure. I'm not sure I'm the author of this, but the way I understand addictive disease, for that matter, any disease, um, first and foremost, I want to be very clear that from in my world, a substance use disorder is as just a real disease as cancer or heart disease. Nobody asked for it. Nobody wants it. Nobody intentionally went out of their way to get it.
Mm,
It happens to us because a lot of people casually drink and they have no problem. A lot of people, believe it or not, are casual cocaine users.
mm.
Not many, but some. Um, and there is a biological foundation to a lot of these, but we don't want to limit it just to that. So I believe that all illness, pretty much, except the purely genetic ones, like Tay-Sachs. Tay-Sachs is a horrible illness. If a kid has it, they're not going to live long. There's not much we can do. But those, thank God, are there are a number of them, but they don't affect a lot of people.
Mhm.
Um, the vast majority of diseases have a biological vulnerability, often genetic, but then there's a psychological component, and that's where the shame comes in, and that also includes usually a behavioral component. Um, the vast majority of cancers that we have to deal with as people are related to the behavioral choices we make. Again, being very clear that none of us say, hey, that sounds like a
Right.
fun thing. You know,
Yeah.
even the person smoking the cigarette. I mean, I had two grandfathers. One of them died at the age of 52 of lung cancer. They both smoked unfiltered cigarettes and drank a bit. Um, the other one died at the age of 86,
Wow.
clear lungs, death certificate read natural causes. Smoked 2 to 3 packs of unfiltered cigarettes.
Wow.
He had obviously some genetic resiliency in the face of that disease. So the way I understand addiction or all disease, biological vulnerability, psychological liability, social context or isolation, spiritual bankruptcy,
Mm.
and then experience mixes those all up, and it's how they line up, and if they line up in an unfortunate way, poof, you've got the disease.
Right.
So it's the psychological variable where shame comes in. And I talk about shame as the psychological driver that pushes addiction toward expression in a person's life.
Mm.
And I, for years in this field, we looked at a person's use of a chemical as if it was enjoyable, as if they were meeting some positive need. That's nuts.
Mm,
It may be, I mean, it may be enjoyable to smoke a joint every now and then. I mean, I don't, but that's
mhm,
because of my history.
mhm,
Um, but the bottom line is, once drug use or alcohol use crosses into a substance use disorder, now you've got a disease.
mhm,
And no disease is fun. And what is very clear, people continue to use in order to medicate, in order to defend against a greater physiological and psychological pain.
mm,
And I talk about shame as kind of almost like a pain in the soul. There's something missing. I'm not good enough. I never, no matter how I try, I always screw it up. You know, I desperately want to have relationships, but they just never quite mesh.
mm,
So there's this constant internal sense of failure, and um, I think it's really important to recognize that shame, just like this whole category that we're talking about, adult children of addictive illness, it's not a diagnosis.
mm.
We all have some shame. We just do, because parents are imperfect, and at times they fail to be there when we need them, and that's just the way it is.
Yeah.
Um, I think I think if shame wasn't so ubiquitous, we wouldn't have shame stories in the vast majority of major religions.
Yeah.
And Christianity has a great one. It's called the Garden of Eden.
Yeah.
And and shame is different from guilt. Guilt is about what we did.
Mm,
Shame is about who we are. And
mm,
literally, if you go back to that powerful piece in the Bible, once they eat the apple of their own knowledge, it's not that God gets angry at them for what they did. They suddenly become ashamed of who they are.
mm. Wow.
And they don't deserve to live in that garden. Hence,
Mhm.
they are, in a sense, exiling themselves.
Right.
And that's what shame does.
Wow.
Shame exiles us from the possibility of having the full, uh, uh, joyful, and fulfilling lives that we all deserve.
Yeah.
So we have to work on that, um, and shame would be probably the number one thing I work on with the patients that I'm, again, privileged to treat. That
Yeah.
that that they've got to realize first that they didn't deserve those shaming messages,
Mm-hmm.
and begin over time, slowly and respectfully, to to begin to substitute different messages
Mm.
for the judgmental ones that they are convinced are real.
Yeah. Yeah. Yeah.
So I think shame, I not only think shame is kind of the enemy at an individual level, I think it's a cultural problem. I think
Yeah.
we live in a shame-based culture, and that's a problem.
One of the things that this is just so helpful for me to understand is, growing up, I had heard always these statistics, and I don't know what current numbers say, but the number was always, 70% of children who had an alcoholic parent will become an alcoholic themselves, or have a substance use disorder themselves. And I just remember thinking, gosh, that is such a high number to be based purely on kind of this genetic input. Um, and kind of coming to understand that another piece of this is, if we grew up in this environment that uniquely exacerbated the sense of shame that we felt, that it made so much sense that a part of substance misuse was an attempt to silence that shame, a
Right.
sense to put that to rest or quiet that voice of shame that's functioning. And then it became so much more reasonable in my mind of, yes, it makes so much sense that so many of us would end up in that ourselves when we are dealing the rest of our lives with kind of this shame that's operating below the surface, but we're trying to quiet it. Just understanding that made so much sense to me. So thank you for
Well,
that.
and I think it's, I don't think you can exaggerate the importance of that.
Mhm.
If you're living with that shame, and you don't feel like you deserve uh, the quality of life you see in others, um, and you have the right biology that responds in a positive way to a particular class of drugs,
Mhm.
and you have that first drink. I mean, for many people, that first drink is dreadful.
Yeah. Yeah.
For some people, however, that first drink, or at least the second one that follows it, is magic, because
Mhm.
that shame disappears. Alcohol is an anesthetic,
Wow.
and literally we can give a person enough alcohol and amputate a foot if we have to. And we
Mhm.
did that back in the Civil War. We had to. We didn't have the kind of painkillers we have now. Well, we had them. We didn't have the quality hypodermic needles. But
Yeah.
the point is, alcohol and many of the other drugs of abuse are are painkillers or distractors,
Mm.
and that shame temporarily
Wow.
disappears. And I cannot tell you how many of the patients I talk to, when I ask them, uh, first, how does their alcohol help? They
Mhm.
have it at times a hard time until I ask them, well, think back in your early experiences. What was it? And they will often say, yeah, it made the shame go away.
Wow.
It helped me, and what is powerful, it helped me feel normal.
Mm.
Now let's wind that all the way back to the statement we started with, that
That's right.
ACOAs have a hard time knowing what normal is. What what the person doesn't realize, who's struggling with a alcohol use disorder, shame is normal.
Yes.
But they don't know that. But they also have an exaggerated form of shame, and it's more toxic. But they don't know that we all struggle with it. So their idea of normal is to have no shame at all, and
Yeah.
that isn't true.
Wow.
We, so
Wow.
it's this interesting combination
So
of
simple.
helping people recognize that they don't deserve the degree of shame that they have, but that, yeah, you're gonna still every now and then have one of those feelings of, I'm not good enough, I didn't worth, whatever. It's gonna come up,
Yeah.
and let's find other ways that
Mhm.
you can deal with that. Like,
Wow.
go get a hug from your partner.
Yeah. Yeah.
I mean, that sounds silly and simplistic, but if you go back to that book that you referenced, The General Theory of Love, if we allow ourselves to be loved by people who are healthy and lovable, that literally changes our brains too.
Yeah.
So,
Yeah.
the
Wow.
sense of community, the sense of connection, going back to Vivek's book, so much of this is absolutely essential to healthy, normal functioning,
Mm.
and it's doable,
Yeah.
even for people who come out of some of the most challenging childhoods.
Yeah. Jeff, I could talk about this all day. This is so helpful, so wonderful. So thank you so much for your time, for being a part of these conversations. Last question, anything that you're working on that you're excited about, or if people want to hear more from you, where can they see some of your work that you've done?
Well, they can go to there's a website, Georgi Educational Counseling .com. They can Google my name, and they can find it that way, Jeff Georgi. As I mentioned to you as we were talking, before the interview, I am writing a book,
Yeah. Yeah.
which hopefully will be out by late winter, and it's called Beyond Shame:
Okay, great.
Redefining Addictive Illness.
Wow.
And there are a number of podcasts and things on our website that's growing that people can utilize. And I am still in private practice. I'm busy, but I certainly would be open to helping folks if they want to look for that level of help. As is my wife. I work with Becky, and she is a trained therapist. Um, she has a greater focus on the collegiate population, but that's another just way of saying there's help out there, and it doesn't have to be me. If you're struggling, please ask for help. Go to your pastors. Say who do you know?
Yeah.
Um, and so I think those are the ways people could access some of the
Great.
things that I spend my time talking about.
Yeah, I love it. Well, Jeff, thank you so much. Really appreciate your time.
You are welcome.